June 26th, wrongs part 3. This is the last section before we just decide to jump off a boat with wrongs. We end this one pretty rough too. In the beginning, they say the patient has superior vena cava syndrome. Doesn't seem totally, that's pretty much what we were on. We ended up picking thoracotomy. They wanted to do radiation therapy because and their reasoning is sound here. Okay, they've got superior vena cava syndrome with a history of non-Hodgkin lymphoma, and we know that those people are even more likely to have malignancies, and we know that malignancies are linked to superior vena cava syndrome. So it's not that outlandish that the answer would be radiation therapy. Next is another one that was just not that crazy, and we just missed it. Okay, so 10 days after having a vagotomy, pylorostomy, oversewing a bleeding duodenal ulcer, a 67-year-old dude has a fever and difficulty breathing with a pertinent X-ray finding of a raised left hemidiaphragm. And we're picking vagus nerve injury on the premise that it said vagotomy, which just kind of just brought us there, and then saying, well, left raised left hemidiaphragm. What if it's like the nerve? What if which is usually would have been the phrenic? And go figure, the answer is subphrenic abscess. But in any case, the vagus nerve injury is not right. They want a subphrenic abscess. They've got a raised left hemidiaphragm with a fever. It's not that wild. Okay, just isn't. Next up, another not crazy one, y'all. Getting killed here. CLL. They had CLL. They were 67. They had a leukocyte count of 84,000 with lymph nodes. And it says, what are they at greatest risk for? And we said, well, cancer puts you at viscosity risk. So let's do hyperviscosity syndrome. No, it's infection. Okay, cancer is going to put you at risk for an infection. It says hyperviscosity syndrome can be seen in patients with CLL, particularly if their lymphocyte count's high. Increased viscosity of the blood can lead to symptoms like headaches, dizziness, blurred vision, and severe cases of seizures and stroke. But infection is far more likely. Severe cases of seizures and stroke. But infection is far more likely in a patient with CLL. Next up is them just kind of just playing to like it couldn't be this easy. They have high calcium in the serum and not very much calcium in their pee. Okay, so they have 50 milligrams of urine in their pee of calcium and 11 milligrams of calcium in their serum. And it's a 40-year-old chick with no family history of having this condition, except for mom had kidney stones. So parathyroid hormones high, doesn't matter. It's not primary hyperparathyroidism. It's familial hypocalciuric hypercalcemia. They are going to defend themselves on saying that the markedly decreased 24-hour urine calcium excretion indicates FHH as the likely diagnosis, and a genetic test can be confirmatory in a patient with equivocal findings. Next is kind of a story we've seen before. So 27-year-old dude, he has a past medical history of asthma, 10-year history of chronic cough, productive student. He's got 3-year history of intermittent diarrhea. In the last 2 tract antibiotics, 3 episodes of pneumonia. He says he uses his albuterol inhaler 4 times a day. Now this one, that's fine. Okay. Normally, I would have thought that the answer here would have been more something along the lines of like, can we manage this person's condition better? But what they're actually looking for is here, this is like a weird common variable immunodeficiency disease. I feel like we had a question in the past where they have just like all low immunoglobulins. In the explanation, it's saying they can have decreased IgG, low concentration of IgA and or IgM. And it's saying they can have decreased IgG, low concentration of IgA and or IgM. And that's common variable. So really just like 25 to 35-year-old person that all of a sudden keeps getting weird infections, including plus or minus diarrhea. That might be a common variable immunodeficiency disease. 5-year-old kid, he's got right upper quadrant pain. We went with splenomegaly, okay, because he also has splenomegaly. And he's got hereditary spherocytosis, which for some reason just rang a bell with splenomegaly. He's got hemolytic anemia. It's obvious to us that he has hereditary spherocytosis. He's got anemia, and they tell you that he has small, uniform, spherical erythrocytes. But they're saying that his abdominal pain is biliary colic that happened 1 hour after he ate dinner. Yeah, just a stats question where they don't put the sick on the top. Yeah, just a stats question where they don't put the sick on the top and the not sick on the, they don't align the chart the way they normally do. They're saying that you want to use this oxygenation index to predict deaths. So in that particular instance, you should have just used only the stuff that had to do with deaths. They're saying which one of these is the sensitivity of predicting deaths. So just take just only the columns that have to do with death and then do sensitivity for that. This one, we had a bad feeling about it. It's ITP. It's pretty clear as day. It's ITP. She's pretty much fine. She's got purpura. She has some itchiness, rashiness, with a super low platelet count, 9,000, but no symptoms. So they still want to just do the steroids. They just do prednisone. They say platelets is very reasonable if she was actually sick, but she's not actually having any symptoms other than the rash. You missed a 65 to 75-year-old. You missed a 65 to 75-year-old AAA. You screened for. They were an ever smoker doing abdominal ultrasound. Just keep that in the back of the mind. It's like a day one thing. They have a 17-year-old that they tell. I mean, it's androgen insensitivity syndrome. They've given you everything. And they're saying, what's the next appropriate step in management? So you did the gonadectomy because that's what you're supposed to do. And that's what it tells you you're supposed to do. But they wanted you to confirm it with a karyotype first. Can you believe it? Confirm it with karyotype. What difference does it make? Okay. They've got no uterus, no ovaries. What are you karyotyping here? This makes no sense. Just take the undescended testicles out. It's nonsense. A gender dysphoria kid that they want you to say they have MDD and not body dysmorphic. You're saying body dysmorphic manifests as a preoccupation with a perceived flaw in physical appearance leading to repetitive behaviors like checking or mental acts comparing appearance to others. So they're saying that they're saying that the person is distressed by their body as a whole, not a particular flaw. And they have a sense of being internally different from others, just consistent with gender dysphoria. So they're just going to want you to go apparently that the gender dysphoria person has depression. And if you would have just given them gender affirming treatment, then that would decrease the possibility that they would have depression or suicide. This kid has a 3-centimeter penis when he's 13 years old. You're supposed to just tell him that that's normal. Scrotum was pink and enlarged with a sexual maturity rating of 2 at 13 years old. And you're supposed to just tell him. You're supposed to just tell him it's normal. If they do a VQ scan and the VQ scan says that there's a high probability of PE, then you don't have to do anything else. It's kind of funny because this is the flip of the other one, where the other one was said, they said that the VQ had a low probability of PE, and then you're supposed to do the spiral CT because you're supposed to just not trust it. And so now this time it says that there's a high probability of the P on the VQ scan, and you're not supposed to do the spiral CT because you're supposed to just trust it. I could have swore that I saw somewhere that donepezil was linked to urinary issues. It was pretty clear that they had overflow, bladder overflow type of situation, but they had a drug of donepezil on there. This is saying that they don't think that any of the drugs that the patient was getting, which includes the donepezil, they're saying, well, they don't think that any of those cause urinary incontinence. And so when they had a soft, non-tender midline mass below the umbilicus in a patient who's had some low volume urinary incontinence. Yeah, I mean, it sounds like neurogenic bladder to me as well. But I just could have swore that I had seen somewhere uh, about neurogenic bladder with this.